Recording. All right, welcome to our check-in session for this week, October 29th. Hopefully everyone can hear me. If we get knocked out for whatever reason, knocked offline, please just check. If we can't get back in more than 5 minutes or so, check on your Canvas site a little bit later for this session or information that we'll be covering here today. Okay, it's a little bit rainy out here, so hopefully we'll be able to stay connected. All right, so let's go ahead and get started then. So today, as I always do, just to remind you what we're trying to accomplish here today, we'll review key information that we've covered this week. Also provides you with an opportunity to ask some live questions. We'll be looking over what we've done this week by way of a summary / overview, and then have an opportunity for you to ask questions, and also have an opportunity a little bit later too at the end of the session for a more formal type of Q&A. Just to remind you too, for the course flow, there's always, you have to read the textbook chapters, complete the quiz homeworks, and also utilize the lecture notes that I do provide for you and annotate those, as well as view the recorded lectures that I established for you guys as well. Now, also, I'll remind you a little bit later, but there is going to be an exam that's open for you guys today. They'll be open until next week, I think the 1st of the month. All right, now using your chat feature, please send to me, your host, that you are present here. So just send me that you're present so I have you listed here. So when I start calculating a little bit extra bonus points for you guys, I'll be sure to provide you with some as well for attending these sessions. I'll wait for a few of you to do that. And I will try to remind you a little bit later too if some additional people pop in after we've gone ahead and started the session. Okay, let's go ahead and continue. So what we're going to be talking about today is chapter 14, which is focused on psychological disorders. Previously, we covered the chapter on personality, and so now we'll wrap up this particular unit for this session for psychological disorders, chapter 14. So what we'll be looking at is the following. Today, we'll be looking at what does it mean to have a mental disorder, defining and classifying disorders. We'll be looking at certain disorders like anxiety disorders, including GAD, panic, phobias, OCD, and PTSD. Mood disorders, including depression and bipolar disorder, schizophrenia, and other disorders such as dissociative disorders and eating disorders. So what is it? What do we mean by psychological disorder? Well, what we mean is a significant dysfunction in an individual's cognitions, their thoughts, emotions, their feelings, or behaviors or actions. So some sort of dysfunction in those key areas of someone's behavior, emotions, or cognitions. Disorders are diagnosed when there is a dysfunction. Behaviors which are considered maladaptive because they interfere with one's daily life. So we all have some sort of issue, but when does it rise to the level of a disorder? That's what we're saying here. One, if there's a dysfunction that interferes with one's daily life, meaning you can't hold on to relationships or you can't keep work, whatever the case may be, it's having some sort of impact on your daily life. In addition to that, disorders are diagnosed when the symptoms and behaviors are accompanied by distress or suffering. What we mean here is this: the person who's experiencing this disorder is very stressed out because of it, or they're suffering because of it. So the two things here to remember is this: one's daily life is being impacted, and two, that you are suffering or having some sort of distress. One or both of those things would possibly rise this particular issue that one has up to a level of a disorder. Now, I also want to point out the difference between a disorder and disease. Sometimes you hear something about a disorder, and sometimes you hear something referred to as a disease. Well, the term disorder is used instead of disease because the latter term, disease, typically implies a known cause of the symptoms. So we know, when we say disease, we normally know what is causing those symptoms. We know more clearly what it is. In naming something a disorder, you're not naming a cause such as a virus. Instead, you're naming a collection of symptoms that tend to go together. So we are talking about psychological disorders based on symptomology. Okay, the symptoms that tend to travel together for this particular described or labeled disorder. So that's the difference between a disorder and a disease. So let's look at an example real quickly here. ADHD, attention deficit hyperactivity disorder. This is described as impulsivity mixed with inattention and or hyperactivity. All right, inattention and or hyperactivity. And everyone probably knows someone who has been affected by this. Okay, and what we want to ask here, is this a disorder? All right, so it can include distractibility, disorganization, fidgeting, difficulty express or suppressing impulses, impaired working memory. So is it a disorder? Let's look at what we just used to describe what a disorder is when it comes to the idea of impacting one's daily life as well as causing some form of distress. So is it deviant? Okay. Do some people have a level of inattentiveness, impulsiveness, and restlessness that goes beyond laziness or immaturity? Yes, some people do that. They have something that is not just laziness or immaturity, there's something more significant. Is it distressful? Is the person enjoying being energetic, or are they frustrated that they can't sustain focus? They can't sit down for 50 minutes to pay attention to someone give a lecture, for example. So that's a yes, it can be quite distressful. So it is odd or deviant from the norm, and it can be distressful. And finally, is there a dysfunction? Are the symptoms harmless fun, or do they negatively impact work and relationships? So the idea is that, does it have some impact on your daily activity? Does it cause some sort of issue there? And the answer there, again, is yes. So based on what we know about ADHD, it's deviant, it's distressful, it does have some sort of dysfunction, it would fall into the category of a psychological disorder. Now, obviously, there are some controversies associated with this because some people think that this is being over diagnosed, and there may be some legitimacy to that. So the idea is that we use these things as a guide to help us understand when something is at a level of a disorder, and ADHD is one of the examples that we've just gone over here. All right, I'll pause. Are there any questions so far before I keep rolling here? You can send me a chat or speak up. Doesn't seem to be anything at the moment, so let's go ahead and keep going on. So that's what we mean by a psychological disorder. So we've talked about what a disorder involves, the idea of a dysfunction, the idea of causing stress, and we've seen an example here by looking at ADHD. So let's look at understanding the nature of psychological disorders. All right, one reason to diagnose a disorder is to make decisions about treating the problem. So we need to diagnose that there's something there so we have some way of treating it. In the past, based on older understanding of psychological disorders, treatments have included such things as exorcising evil spirits, beatings, caging or restraining people, or trephination. And trephination is basically when they would drill holes into the skulls of individuals who are being afflicted by some sort of odd behavior, some sort of psychological disorder. At the bottom left of the slide here, you can see a skull that was found that has evidence of trephination, that they drilled a hole into this individual's head. Sometimes the head, the hole will be drilled in the head because it may be allowed evil spirits to leave the possessed body. All right, so that was the idea that we've seen in the past when it comes to psychological disorders, what causes them and how to treat them. So eventually a new voice came onto the scene, Peniel, his new approach. He proposed that mental disorders were not caused by demonic possession, but by stress and inhumane conditions. He suggested a moral treatment. So he wanted to have gentleness, have the person around nature, outside nature scenes and sort of things of that nature, and provide some sort of significant social interaction. So with moral treatment, Pennell's interventions improved lives, but did not really address the mental illness directly. So it didn't effectively treat mental illness. Now, one thing that did help the movement to try to figure out ways to treat these types of disorders was this: the discovery that the disease of syphilis, a sexually transmitted disease, syphilis, caused mental symptoms by infecting the brain. So the idea is they would notice that individuals who had caught syphilis, they would start to display unusual behaviors themselves, based on the fact they discovered that the brain had become infected as well. What this did, it suggested a medical model for mental illness. So now it made people start to think that maybe these mental illnesses may have other causes very much different than demonic possession, but causes that are physiological, that may cause some change in people's behavior and their mentality. So that led to the medical model. So the medical model is now where we are when it comes to psychological disorders. Psychological disorders can be seen as a psychopathology, an illness of the mind. So now we're going away from spiritual stuff, from evil, demonic possessions. Now we're seeing it as an illness of mentality, an illness of the mind. By opening it up to this medical model, disorders can now be diagnosed, labeled as a collection of symptoms that tend to go together, all right? Because it's a disorder, not a disease, okay? But so we have these symptoms that tend to go together, and people with disorders then can be treated, attended to, given some sort of therapy with the goal of trying to restore them to proper mental health. So we went from not understanding what was going on to suggesting that it was demonic possession to now understanding that possibly we're looking at a medical model saying it's the illness of the mind, meaning that we can get people better through some form of treatment. So the biopsychosocial approach to psychological disorders. Today's psychology studies how biological, psychological, and social cultural factors interact to produce specific psychological disorders. Although I didn't include it in this particular presentation here, but when it comes to social cultural factors, there are certain disorders which are culturally bound. And what I mean by culturally bound, there are certain types of disorders that we see in some cultures, but not others. So a culture-bound syndromes are disorders which only seem to exist within certain cultures. They demonstrate how culture can play a role in both causing and defining a disorder. Give you one example. We normally see bulimia nervosa, which we'll talk about a little bit later, which is one of our eating disorders, where you have people who binge on food and then purge the food they've consumed in one way or another. That's usually seen only in cultures like ours in the United States. So that's one of those culture-specific or culture-bound types of disorders, okay? So moving on. Now let's look at how it is that we classify and why it is that we classify these psychological disorders. Classification is very powerful, and it's a very powerful tool as well. So we classify or attempt to classify psychological disorders for three reasons. One, to provide a verbal shorthand for referring to a list of associated symptoms. So we have a bunch of symptoms. Let's say, for example, you have someone who's having some sort of issue in their life. They go to a doctor, maybe their primary care, or maybe a psychiatrist or psychologist, and the doctor listens to all the symptoms they have. Well, these symptoms can sort of represent a verbal shorthand because they have a resource they can use called the DSM that they can look in to see what do these symptoms, what are they associated with? What type of diagnosis? So by having a classification system, it allows for a verbal shorthand for us to be able to describe these collection of symptoms. Two, the diagnosis allow us to statistically study many similar cases and learning to predict the outcome. So now we have a verbal shorthand for symptoms. Now we've identified them with some sort of label, and then we can sort of follow how well the individuals are being treated. So what type of treatments work, what didn't work, were these differences between this treatment protocol and that treatment protocol significant? They can only do that now by having this verbal shorthand and these labels, and then being able to statistically examine them. And number three, the diagnosis can guide treatment choices. So by having the verbal shorthand, by having the ability to analyze it statistically, we then can figure out ways that we can treat individuals who have certain type of symptomology or certain types of disorders. Now, what we've been talking about here is something called the Diagnostic and Statistical Manual, the DSM. In order to make the definitions clear, each diagnosis in the DSM includes a list of symptoms, often in groups, and the DSM includes criteria of how many symptoms must be present in each category to justify someone being labeled with a particular psychological disorder. So you go into the doctor's office, you list a symptoms that you have, a list of symptoms that you have, and if you have enough of the symptoms, okay, that match up with a particular type of label or disorder, then the doctor could say to you and diagnose you with a particular type of anxiety disorder, for example. So that is what we normally do. We use this DSM to help us communicate, research and learn, and guide us to certain types of treatment. But when someone is labeled, there does have a certain type of stereotypes associated with it, potentially. So many people think a diagnostic label means being seen as tainted, weak, or weird when it comes to psychological disorders, because there is still somewhat of a stigma associated with someone going to seek some sort of help. It's not as much as it used to be decades ago. So more people are a lot more open to people seeking treatment for issues they may be having. But the label itself can have a power to it. There was this one classic study, I didn't talk about it previously in the lecture. I think it was a study by Rosenhan, and he got somebody who was totally healthy and sane to say they had certain symptoms and check themselves into a mental institution. And then once they get checked into the mental institution, they would state the symptoms are gone and they would just act normal. And they wanted to see how the staff and doctors would treat this person who was acting normal in a mental institution. And lo and behold, obviously they continue to see the person as having the symptoms that they said they had when they came in there initially. So despite them acting normally, people still saw them as the label, as the disorder that they came in with. So that's just the power of labels and things of that nature. They have a great deal of power to them. So that, along with other things, there are critiques of diagnosing using this particular manual. Here are a few of them here. One, the DSM calls too many people disordered. So if you look at the DSM and look at all the people out there, many people would be considered to be disordered. Two, the border between diagnosis or between disorder and normal seems to be arbitrary. So they say, if you have this number of symptoms, you're fine. You have that number of symptoms, you have a disorder. So that's arbitrary nature of the DSM. Decisions about what is a disorder seems to be put as a value judgment. For example, is depression necessarily deviant? Case in point, believe it or not, several decades ago, the DSM listed homosexuality as a disorder. That has since been changed, but at one point it was seen. So we see there sort of a value judgment in the DSM. And four, diagnostic labels direct how we view and interpret the world around us, telling us which behavior and mental states to see as disorder. So there are some things we can't avoid when we have something like the DSM to help us in diagnosing psychological disorders. So it's not without some critics, but it is a tool that has been quite useful to the mental health field for a long time now. All right, any questions so far or comments? Okay, so now let's start looking more closely at some of the class of disorders. First, we'll look at anxiety disorders, which include OCD and PTSD. Anxiety disorders are characterized by distressing, persistent anxiety or dysfunctional anxiety reducing behaviors. What that basically means, you have this anxiety, this tension about something that's going on, or you have something that's interfering with your life because you are doing a bunch of anxiety reducing behaviors, things to make the anxiety go away. Okay, so that's what we mean, generally speaking, by an anxiety disorder. Now, here are some of them. We have generalized anxiety disorder, GAD, G-A-D, is an anxiety disorder in which a person is continually tense, apprehensive, and in a state of autonomic nervous system arousal. So this individual is always sort of like on red alert, okay, or at least yellow alert, very, very close to red alert. They're always very tense. They feel like something's about, the other shoe's already about ready to drop, or they feel like there's an axe hanging over their head. They have this anxiety, sometimes referred to as a free floating anxiety. That's not about any particular thing, but you have this anxiety that's somewhat generalized, and that's how the person sort of lives their life. It can be somewhat stressful. Then we have panic disorder. This is an anxiety disorder in which the anxiety suddenly escalates at times into a terrifying panic attack. It can be a minutes long episode of intense dread in which a person experiences terror, accompanied by usually a racing or irregular heartbeat and chest pains. It can almost at times feel like someone is having a heart attack. Now, interestingly enough, once you have your first panic attack, and I know people who've had them, I've had one before. Once you've had that first panic attack, when all of a sudden things seem to be going well, then all of a sudden you have this intense dread, and you need to get out of wherever you are, elevator or in a car, what have you, whatever the case may be. Then once that happens, you then have this ongoing fear, anxiety of it happening again. So it sort of like compounds itself. So you've already had a panic attack, and now you have this fear, anxiety about having another one. So let's say you have this important job interview, and you worry in the back of your mind that maybe during this job interview, what if you have a panic attack? So it just compounds itself and makes itself even worse for the individual suffering from it. Then we have phobia. A phobia is an anxiety disorder marked by a persistent, irrational fear and avoidance of a specific object, activity, or situation. Specific phobias can focus on animals or insects, heights, blood, closed spaces. There are many types of phobias out there. But the key factor here is this. We're talking about a fear that is irrational or way out of proportion to the actual posed danger that this object may actually represent. So it's a phobia is sort of out of whack with what the real danger is, so it's somewhat irrational. Now, phobia disorders is probably the most common type of disorders we have. But phobia disorders can be somewhat managed to some extent, because if you have the ability to just to avoid the thing that causes the fear, then you do so. You manage your life to avoid those particular type of situations. All right, but it is one of the more common types of disorders out there, phobias. Then we have OCD, or obsessive compulsive disorder. This is a disorder characterized by unwanted, repetitive thoughts, obsessions, and responses to those thoughts, compulsions. For example, there's a classic one where you have people who are afraid of germs and dirt and filthy things. So they are obsessed about it. They're always thinking about it. And it may also not only cause issues with the obsessions, it may lead to compulsions. A compulsion of that could be someone who always washes their hands every opportunity they get. They're washing their hands and scrubbing them really, really hard. So here we're seeing an obsession and a compulsion. Obsessed over germs and compulsed to wash your hands constantly. Some people can wash their hands 400 times a day. And obviously, if you're washing your hands 400 times a day, that's most of what you're doing. At every spare opportunity you have, you're washing your hands. It will interfere with one's life and their work, obviously. All right, so that's OCD. And then we have post-traumatic stress disorder, PTSD, as most people have some familiarity with that. It's characterized by haunting memories and nightmares, a numb feeling of social withdrawal, jumpy anxiety, trouble sleeping, and things of that nature. They can be very hypervigilant, always sort of like very tense and ready to spring into action. Okay, we see people relive the traumatic event very clearly with memories and feelings popping back that they experienced during that trauma. Now, normally when we hear of PTSD, we think of individuals like police officers or military personnel, and they can suffer from PTSD, but anyone who's had a traumatic event can also suffer from that. Someone who's been in a really bad car accident, for example, can also suffer from PTSD as well. So that gives us some idea of some of the anxiety disorders out there and what they are. Now let's try to understand a little bit about what these anxiety disorders are. So the research out there has indicated that there seems to be some predispositions to certain types of fear. So there seems to be some role that genes may play in our anxiety disorders. We also see classical conditioning, overgeneralizing a conditioned response. We saw this as well previously in the course when we talked about the little Albert study done by John Watson and Rosalind Rayner, where they conditioned or programmed into little Albert emotional fears that then were generalized into other things as well. So these overgeneralized, a conditioned response can be a root cause of some of these types of anxieties that one may experience. We also have operant conditioning, where rewarding avoidance. And what we mean by this is when you have a fearful object that you have a phobia about, and you avoid it, you have the negative tension that results from you seeing it, but then you avoid it, you get negatively reinforced for it. So something that you didn't like is taken away, that's reinforcing. So again, that strengthens the anxiety disorder to some extent. Then we have the brain. The brain, once it has these active anxiety pathways, they become more readily activated at times. In addition, we have cognitive appraisals. Uncertainty is danger. So when we are uncertain about things and we appraise it as uncertain, we don't know the outcome of it, can cause sort of a worry circuit in a way. And so this also can help us to understand how these anxiety disorders work. And then there's natural selection, surviving by avoiding danger. There are certain things that we may tend to have a natural degree of avoidance of. And it could have been in the past that these natural phobias, these fears, were very good for our ancestors because it helped them to survive. So by avoiding danger because they had a fear of snakes, they were able to survive long enough to have offspring, so that we still have that characteristic today. Whereas those who did not have the proper fear and respect of certain animals out in the world, they did not live long enough to have offspring because they got bit or be eaten. And then finally, we have observational learning. Avoiding and fearing can be modeled. So you have a young kid traveling with, let's say, their mother or their grandmother down a sidewalk, and a homeless person that is very much unlike them is walking on the sidewalk as well. And then that older person takes the kid and moves him to the other side by way of trying to protect the kid from the stranger walking towards them, and their body language changes and they become somewhat fearful. Well, the kid is observing that type of behavior. That behavior of fear and avoiding is being modeled, and therefore the kid is learning that behavior for that particular type of person that's walking toward them. This idea has also been suggested as a way in which sometimes people are taught certain types of prejudicial types of attitudes as well. So these are a variety of ways in which we can see and understand how anxiety sort of works and why it's sort of maintained to some extent. So now let's move on to the other disorder of depressive disorders or mood disorders. And this includes major depressive disorder and bipolar disorder. Now, I want to make a note to what we just left here, talking about anxiety. Note that anxiety is a response to the threat of a future loss. So when you're having anxiety about something, this is about something that could happen in the future. Nothing has happened yet. That's what anxiety is, future focused. All right. Whereas when it comes to depression, depression is often a response to a past or current loss, something that's happened in the past or something that is somewhat of a new or current loss that we've gone through, not the future as we see in anxiety. Okay, so now let's look at major depressive disorder. This occurs when at least 5 signs of depression, including either depressed mood or loss of interest or pleasure. So you have this depressed mood, you just lay in bed all day, you're not really interested in doing anything, you have no initiative, things that used to bring you pleasure are not pleasing you anymore. And it lasts 2 or more weeks and are not caused by some sort of drug or a identifiable medical condition. That's what we mean by major depressive disorder. And then we have bipolar disorder. It used to be called manic depression. Bipolar disorder is a disorder in which a person alternates or switches between the hopelessness and lethargy of depression and the overexcited state of mania, where you have hyperactive, you're wildly optimistic, everything's wonderful, you can do no wrong. If you buy something or go buy lottery tickets, you know you're going to win. That's mania. So bipolar is going from depression to mania and then back again. So those are the 2 key forms of our mood disorder. Now, depression is everywhere. Depression shows up in people seeking treatment. Phobias, as I stated earlier, are the most common and frequently experienced type of psychological disorder. But depression is the #1 reason people seek mental health services. Okay, so phobias are the ones that we have most often, but the reasons that we go seek help is when we are depressed. Now, there's another type that I want to mention here of depression that falls in this category as well, a mood disorder. It's called seasonal affective disorder, or SAD. Seasonal affective disorder involves a recurring seasonal pattern of depression, usually during winter's short, dark, cold days. And this really interesting study, a very simple study, was done, and it shows us how it can have an impact on us. So they simply would ask the question of a group of people, have you cried today? When they asked that question in August, 4% of men said yes, they had cried that day. 7% of women said yes, they cried that day in August. They then asked the same question of a different population in December. In December, 8% of men said they cried that day. So it doubled for men. But in December, 21% of women. So it more than tripled for women. So we see that the seasons can have an impact on our moods as well. And that's why we tend to see certain behaviors, unfortunately, during the winter months where people are really somewhat more prone to depression. So what about these mood disorders? In order to understand mood disorders like we did with anxiety disorders, let's look at a few things here. First, let's look at the evolutionary perspective and the biological perspective. Depression in its milder, non-disordered form may have had a survival value in the past. Could be one of the reasons why it still is around to some extent. Under stress, depression can serve as a social, emotional hibernation. Hibernation is when an animal like a bear or something goes into this cave and just rests out the winter, just to relax, so to speak, and not be involved in things. So what they're suggesting here is that in depression, we have this social emotional type of hibernation. It allows humans to conserve energy because they're not doing that much. They're just laying around for the most part. Avoid conflicts and other risks because now you've taken yourself out of the game, so to speak. So you're not conflicting with other people, all right, and things of that nature. And you have you've let go of things, unattainable goals. So you just take yourself sort of out of the game for a while and allows you time to think, all right? There's one question I want to see if I can address here. If a person has a panic attack or anxiety attack at one time, would the person be diagnosed with a psychological disorder, or would the panic attack have to be frequent? I'm not certain about what the details. It would depend on the individual with regard to is one enough, but I will tell you, having suffered from a panic attack, once you've had one panic attack, and it is a serious type of thing, it does leave a mark on you, meaning that what happens is you remember that panic attack because it was very significant to you personally, and you always worry about it. Now, I had a panic attack maybe like two or 3 years ago, I take it, and I was in the car, and I had a overwhelming dread of things closing in on me, and I had to get out of the back seat of this vehicle, and I just stumbled out of the car when the person pulled over to the side of the road. It was that powerful, and I've had a few attacks since then, but I always worry about it. So when I get into a confined, closed space, even an elevator still, I still have that worry, which is one of the insidious nature of once you've had a panic attack, you always worry about, am I going to have another one? So obviously, I would not diagnose anybody. It's not my area, but it personally probably will have a lasting effect. If you've had one panic attack, it will have a lasting effect. Whether or not it's going to be a disorder, you'd probably have to go see someone to see what the specific criteria would be. All right, so that gives us the idea that what they're saying here is, from an evolutionary perspective, at one point, depression may have served a specific role for us. Genetically speaking as well, they've done analysis and understood that there is a DNA linkage analysis reveals that there are certain genes that may be depression type of genes. And then they've conducted twin adoption heritability studies, which basically says when you look at twins, remember, you have two types of twins. You have the fraternal twins, which is basically brother and sister. They have no real greater genetic capability relationship, more so than siblings do. But when we have identical twins, these two individuals have the exact same DNA. All right. And what they've been able to see, as you can see in the chart at the bottom right of your screen here, is that there seems to be some significant relationship between DNA or identical twins and certain disorders. So if one identical twin has a particular type of disorder, there's a greater likelihood that the other identical twin would have it as well, much greater than if you were fraternal twins. So that does indicate some sort of genetic role there as well. And then when it looks at the brain, brain activity is diminished in depression and increased in mania. So when you are depressed, everything sort of slows down with brain activity. When you're going through the mania phase of bipolar depression, then it sort of increases. Then there's the brain structure. What they've seen is that you have smaller frontal lobes in depression and fewer axons in bipolar disorder. So there seems to be some structural differences as well. And finally, we have the brain cell communication, those fun things, those neurotransmitters that we've talked about before. Norepinephrine increases in mania and lowers in depression, as does serotonin levels. So obviously we do see, as we try to understand mood disorders, that there are genetic implications as well as brain structural as well as neurotransmitter implications as well. Now, another area to look at is the social cognitive perspective. So we've looked at structures of the brain and neurotransmitters. We've looked at genes. We've looked at evolutionary perspective as well, but also there's a social aspect as well. So depression is associated with the following: low self-esteem. Your sense of self-esteem is basically considered your sense of value or worth that you see yourself as having. So low self-esteem, discounting positive information and assuming the worst about the self, situation, and the future. That's what we would see with low self-esteem. So that has been associated with depression as well. Learned helplessness, self-defeating beliefs such as assuming that oneself is unable to cope, improve, achieve, or be happy. When someone or organism learned helplessness, they've sort of like given up. For example, you can have somebody who or an animal has been captured and not allowed to leave in these horrid conditions, and they've been in this cage for a long time. There will be a point where they may have learned helplessness, meaning that you could literally open the gate to their cage so that they could leave if they want, but they refuse to. That would be an indication they have just given up and they have learned helplessness. That's what they function at now. And then there's rumination, stuck focusing on what's bad. And we see rumination occur when people just can't let go of something and they keep going over and over and over and over. And that can be somewhat problematic. And rumination, we have seen some evidence out there that sometimes women may tend to ruminate more, okay, which could lead to greater levels of depression as you don't let something go and just keep going over and over in your mind, sort of like re-chewing it in a way. And then we also have this depressive explanatory style. This is a key one that we'll examine a little bit more closely here. Depressive explanatory style. Now, in the previous chapter, we talked about social psychology, and we talked about attribution. We always want to attribute cause to something. Why did this person do that? Why did this happen to me? Attributing cause is a key thing for us social creatures. Now, when it comes to depressive explanatory style, this is what we mean by that. So let's say we analyze bad news. How do we analyze bad news? How do we make sense of something that's bad that's happened to us? And however we do it can predict our future mood. So we have a problematic event. You have a breakup with a romantic partner. And then you're going to make certain assumptions about the problem. The problem is, you could say it's a stable problem. I'll never get over this. Or you could say it's a temporary problem. This is hard to take, but I will get through this. So that's one thing. So how you see that particular problem, is it seen as something that's stable to you, or is it something that's temporary? Then we have, is it global? Without my partner, I can't seem to do anything right. Or is it seen as specific? I miss my partner, but thankfully I have family and other friends and other things that I can deal with. So global or specific, stable or temporary. So how you are analyzing this bad breakup, this breakup with your romantic partner, will determine your future outcomes. And then we have, do you see it as something internal? Our breakup was all my fault. So the person is taking the whole issue with the breakup onto themselves. They see it as an internal thing. Or they can see it as external. It takes two to make a relationship work, and it wasn't meant to be. So depending on how you analyze the bad news of a breakup with a romantic partner, is it seen as stable, global, or internal, or temporary, specific, or external, will determine the outcome, your result that goes along with these views. So if someone sees it as stable, I'll never get over it, global, without my partner, I'm nothing, or internal, it was all my fault, you're more likely to result in having depression. If you see it as temporary, this is hard to take, but I get through it somehow. It's specific, I miss my partner, but I have other things I can do, family and friends. External, it takes two to make a relationship work, but it wasn't working, so it wasn't meant to be. That is successful coping. So that's what we're seeing here. By having this depressive explanatory style, we see that how you attribute things can ultimately lead to depression. Now, this also takes into account the following, something called the depression's vicious cycle. A depressed mood may develop when a person with a negative outlook experiences repeated stress. So you have some sort of stressful experience. The stressful experience, as we saw in the previous slide, can lead to a negative explanatory style. The negative explanatory style leads to a greater depressed mood. When you go through depression, your thinking changes, your behavior changes. You're going to be more prone to a variety of things. more prone to accidents, okay? And what we see as well is that the depressed mood changes a person's style of thinking and interacting in a way that makes stressful experience more likely. So what you see is this vicious cycle where it feeds on itself. The stressful experience leads to the negative explanatory style, which leads to the depressed mood, which leads to cognitive and behavioral changes, which leads to more stressful experiences. This is why it can be very difficult to sort of break this cycle. Okay, so all these things can show you and demonstrate why it is very difficult to try to break this cycle because of these things sort of feeding on each other. All right, any questions there before we move on? Okay, let's keep moving then. So that takes us through the depression's vicious cycle. Next, we want to talk about schizophrenia. One of the areas where people get confused quite a bit. Schizophrenia is a psychological disorder characterized by delusions and hallucinations. Let me clarify real quickly between a delusion and hallucination. A delusion, you see somebody downtown and you tap them on the shoulder because you think it was your friend. It turns out they weren't your friend. So you were sort of temporarily deluded or mistaken from that sensory input, thinking it was someone else or something else. But let's say you go up and you tap somebody on the shoulder because you think it's your friend, but somebody who's standing there beside you realizes there's nobody there at all. That's hallucinations. Everything is sort of like totally made up. There's nothing there for you to confuse. You just hallucinated the whole thing. That's a delusion, is something is there and you just confuse it. Hallucination, there wasn't anything there. It's sort of made up out of whole cloth. So schizophrenia, delusions, hallucinations, disorganized speech, and or diminished inappropriate emotional expression. And literally what schizophrenia means is split mind. Okay, this refers to split from reality, not from personality. So it's not multiple personality. Oftentimes people confuse multiple personality with schizophrenia. They're not the same thing. So schizophrenia here is a split from reality. Okay, so schizophrenia is a form of an example of a psychotic disorder. So let's talk about some of the symptoms that we see with schizophrenia. First, we have the positive symptoms. A positive symptoms basically says here that the presence of problematic behaviors. Positive, the presence of problematic behaviors. Here we have hallucinations, especially auditory hallucinations. These are the individuals who hear voices when no one is really speaking, but they hear the voices that may be telling them things to do. Delusions, especially persecutory delusions where they feeling like someone is persecuting them. And then we have disorganized thoughts and nonsensical speech and bizarre behaviors. So the presence of problematic behaviors are positive symptoms. And then we have negative symptoms. Negative symptoms are the absence of healthy behaviors. Flat affect, no emotion showing in the face. They're just blank expressions. Even if something really bad happens in front of them, blank expression. Something very happy and joyful happens in front of them, blank expression, flat affect. Reduced social interaction. Anhedonia, no feeling of enjoyment. Avolition, less motivation or initiative to focus on tasks. Alogia, speaking less, and catatonia, moving less. So these are the absence of healthy behaviors, are the negative symptoms. This is what we see when it comes to schizophrenia. All right. Now, schizophrenia is a very diverse type of disorder. There are various subtypes of schizophrenia. We have paranoid schizophrenia, plagued by hallucinations, often with negative messages and delusions, both grandiose and persecutory. We have disorganized. Primary symptoms are flat affect, incoherent speech, catatonic, rarely initiating or controlling movements, undifferentiated, many varied symptoms, and residual. Withdrawal continues after positive symptoms have disappeared. So the idea is that schizophrenia, many types of schizophrenia out there. Schizophrenia usually appears around age 20 or so. uh, and it can be something that can be, lasting throughout one's life. It's very problematic type of disorder. Now, oftentimes we hear schizophrenia employed in the movies and TV shows all the time. There's a show, I don't know if it's still on or not, Law and Order. It was on for decades here, but Law and Order would have schizophrenic characters on their show quite often, and sometimes they would be committing all sorts of heinous types of crimes. But it should be communicated here that oftentimes schizophrenia and many people who have psychological disorders, they are not the individuals who are usually going to be committing crimes. It is more likely that they would be the victims of crimes as opposed to the perpetrators of crime. But again, we don't see that portrayed usually accurately in the media. Just want to make sure that was clarified. So let's understand, get some sort of greater understanding of what schizophrenia is. Well, first of all, looking at the brain, there are abnormal structures of the brain that are usually associated with it. Too many dopamine receptors, which can explain paranoia and hallucinations. There usually is a poor coordination of neural firing in the frontal lobes, which would impair judgment and self-control, because we've talked about that before, where our frontal lobes is where we have inhibitions and things that can control ourselves. And then we have the thalamus. The thalamus fires during hallucinations as if real sensations were being received. So that's why these hallucinations may be very, very real to these people, because they're getting the input from the thalamus, which is firing as if there is something there. So that's why it seems so real to them, because basically it is real to them. And then we also see the shrinking of many brain areas and connections between them. So these are some of the things that we see anatomically in the structure of schizophrenics. There are other risk factors too that's associated with schizophrenia, being born with low birth weight, maternal diabetes, older paternal age, and so on. These things have been correlated or associated with higher risks of schizophrenia. And obviously there's a strong genetic component as well, as we've seen previously with twin studies looking at the genetic factors. Identical twins, if one twin of an identical set has the disorder schizophrenia, the other is greater, much greater likelihood of having it as well. So we see structures of the brain, there are risk factors associated with it, but there also is a strong genetic component as well. Now, as we start wrapping things up here, let's look at some other disorders. Dissociative and eating disorders. All right, dissociation is a separation of conscious awareness from thoughts, memory, bodily sensations, feelings, or even from identity. So with a dissociative disorder, it is a dysfunction and distress caused by chronic and severe disassociation. We have dissociative fugue. Fugue is running away. This is where a person may wander away from one's life, memory, and identity with no memory of them, and they may just literally go away, go to a different city, and just forget who they are. Okay, and then we have the one that we see quite often in movies and TV shows, dissociative identity disorder, and this used to be referred to as multiple personality disorder. All right, DID, dissociative identity disorder, is where we have the development of separate personalities, okay, within one body. So we have this one body and they have different personalities. Remember, personality is a consistent way in which a person thinks, feels, and behaves across time and situations. So when you have more than one personality in the same body, it's equivalent to having 2 people, 1 body, or 3 people, 1 body, or 10 people, 1 body. So that is what we see. Now, believe it or not, dissociative identity disorder is usually seen in cultures like ours, Western cultures, North American cultures, that type of thing. So it could be one of those more culturally bound syndrome type of disorders. All right. Now, there are other explanations. DID is somewhat of a controversial diagnosis. Some people doubt if it even exists. Some other explanations has been suggested that it's nothing more than an extreme case of role playing. Okay, some suggest that therapists encourage clients to think of different parts of themselves, and sometimes these different parts of themselves may develop into different identities or personalities. And some have even suggested, maybe some people even see it as possession. Now, there are some evidence for the presence and viability of some form of DID. Different personalities have involved different brainwave patterns. So one personality has one brainwave pattern, a different personality has a different one. Different left-right handedness has been seen in the different personalities. Different visual acuity and eye muscle balance patterns have also been seen in individuals who are different personalities within the same body. So patients with DID also show heightened activity in areas of the brain associated with managing and inhibiting traumatic memories. And normally the way it goes when people think about multiple personalities or DID is that something traumatic happened, usually when the person was really young. Some traumatic event that caused the split to occur, the split of a different personality, someone who can deal with it. So you have the host personality who cannot deal with whatever's going on in their environment at the time, and therefore another personality, another part of themselves forms a personality that's much stronger and more capable of dealing with this particular issue going on at that time. And normally these personalities may not be aware of each other. So the person who's the host, the original personality, has no recollection or memory of the thing that got them to that point, or they lost time as the other personality sort of took over. And the reason why we see this portrayed in movies and TV shows so often, because it is an intriguing idea, because it really puts us into certain types of dilemmas. If, for example, which I referred to Law and Order previously, I think it was a Law and Order episode where the person kills their psychiatrist, but it wasn't the host person. It was a different personality who apparently killed the doctor. And the question is, well, how do we try this individual? Do we believe that another personality could be held accountable, responsible, or do we not hold the host personality responsible for the murder? So obviously, this is one of those things where the not guilty by reason of insanity was sort of designed for, but the notion is it really opens up a lot of dramatic possibilities, and that's why we do see it portrayed so often in the movies and TV shows. Okay, all right, so the last couple of things I want to talk about real quickly here is the last group of disorders are the eating disorders. And with eating disorders, we have anorexia nervosa, bulimia nervosa, and binge eating disorder. These may involve the following types of things: unrealistic body image and extreme body ideal. For example, what we mean by body image is that you have your self-image of your body. And then you may have an image of what you want your ideal body to be. So if you have an unrealistic body image and then an extreme body ideal, like somebody who wants to be like one of those models they see in the magazines or on billboards, which oftentimes those final pictures are touched up themselves, then that may be part of the issue that may contribute to some of these types of disorders. Then we have a desire to control food and the body when one situation can't be controlled. One of the things that we see oftentimes is this: when someone is stressed out because of other things that's going on in their life, they want to try to find something that they can control. And that's when they may try to control something in their life, and that may be control of food and the body, because that's something you can have some say over, because you can't control everything else that's going on in your life. And then this can be associated with cycles of depression as things sort of develop and can cause some serious health problems. So here are some of the key types of these eating disorders. We have anorexia nervosa. Okay, this is the common one that we hear about most often. It's a compulsion to lose weight coupled with certainty about being fat despite 15% or more underweight. Does someone have a question or comment? Okay, so with anorexia nervosa, you have somebody who has a body image that still sees themselves as overweight, even though they're usually going to be well underweight. 15% or more underweight, and yet they're still going to exercise a lot, still going to avoid eating food and things of that nature. We normally see it with adolescent females, but it can also occur with males. Usually it's going to be associated with certain males, for example, if they are a wrestler. And that usually happens because wrestlers are usually going to be a lot more concerned about their weight, and that can lead potentially to this type of issue. And then we have bulimia nervosa. It's a compulsion to binge, eating large amounts really fast, and then purging by losing the food through vomiting or taking laxatives or extreme exercise. Normally, when it comes to bulimia nervosa, you can really recognize someone who's suffering from anorexia nervosa because they are really rail thin. You can see the joints of their bones on their shoulders and their elbows rather prominently because it's like skin wrapped tightly over bones. So they're very obvious to see. With bulimia nervosa, you can't see it. They're usually going to appear to be normal to slightly above normal weight, even though they may be suffering as well. Now, anorexia nervosa, you can die from complications based from that disorder because after a while, once you've gotten rid of all your fat cells, which is what you're doing, your body is going to need nourishment, and you're still starving your body. Therefore, your body will start to consume itself, start to eat whatever it can in order to survive, and then you would have systems failures occur because the bottom is sort of cannibalizing itself. But bulimia nervosa, one of the first things you see, let's say if they're purging through vomiting, what can happen there is first sign would be the acid from your stomach will start to strip away the enamel of your teeth, so you start to have some teeth issues there, dental issues because of that. And then if they're using their fingers to initiate a gag reflex so they can start to vomit, your gag response may become useless to you, and therefore it can be particularly dangerous as well. And then we also see binge eating disorder, a compulsion to binge followed by guilt and depression. Now, why does some of these eating disorders happen? We covered some of the idea about your body image and things, but here are some family factors usually associated with these eating disorders. Having a mother focused on her weight and on a child's appearance and weight can lead to this, some say. We also have a negative self-evaluation in the family. By saying negative things about the person, it can give them an injured body image, which they can try to get some sort of control over that through certain types of behaviors. And for bulimia, if childhood obesity runs in the family, we do see that's a factor that's associated with it as well. And for anorexia, if families are competitive, high achieving, and protective, we tend to see anorexia greater numbers for those types of factors as well. And then some cultural factors. One of the cultural factors is going to be unrealistic ideals of body appearance. And again, because we are a society that is ruled primarily by the media, blockbuster movies, TV shows, magazines, all this type of stuff, that oftentimes those people who are the celebrities are put in front of us, and they have their whole lives and careers about their body sometimes, and they can spend days, weeks on end just trying to sculpt their body. And even when they are probably in greater condition than the average person can be, even when those photographs are taken, oftentimes they can be touched up in post so that you are seeing an image that really is not even real, even for that particular model. So that covers some of the key ideas I wanted to really sort of make sure that we were able to address for this particular chapter. All right, let me go on to the Q&A, see if there are any questions or comments. Before you start, just think about if you have any questions or comments real quickly, but let me go ahead and say a couple of things. I just about finished with the first batch of your papers. I'm very positive so far with results of the writing so far, so that's good for you guys as well. And also note that shortly after I finish this, I'll make sure that your test is available to you. It will be covering chapter on personality and this last chapter we just finished wrapping up on psychological disorders. Well, I have a question out there. Is asked, why were lobotomies used to help disorders? Generally speaking, it could be for a variety of reasons, but normally what would happen is when somebody was not able to be controlled and just was so in such a way problematic to the mental institution where they're being housed. Oftentimes, as a last resort, they would perform a lobotomy, and lobotomy would go in there and basically lesion or destroy certain parts of the brain, which would then control in a way their behavior. And the problem is that they really wouldn't be able to do much more. So lobotomies are not really somewhat of a controversial thing now. I don't know if there's any situation in which they are still done now, but they were done quite a bit in the past. And lobotomies really just take the life out of people sometimes because they can just sit there and drool. It reminds me of a movie, The One Who Flew Over the Cuckoo's Nest, I believe. It's not a movie that any of you would like to watch. It's a really slow movie, but there is a scene, there's a character in this who's just basically a pain in the butt character. He's housed in this mental institution with all the other patients and everything, and he just can't be controlled. He's always in everybody's face and everything, and ultimately at the very end of the movie, somebody who had escaped comes back and visits him, and he sees the mark on the guy's head. They finally gave him a lobotomy, and he's just sitting there in his bed drooling because it's about all he can do. So lobotomies were used to really ultimately control people. That's what it comes down to, that we're being too problematic. All right, any other questions or comments? Again, you can ask it or send me a chat message. Any other comments or questions? Okay, if there are no other questions or comments, yes.
I have one question.
Sure.
When can we get the grade for the current event page?
I have most of those graded right now. I'm finishing up the last pass on them, so probably before this weekend and out, we'll see it. And then next week, I'll have a special section, or at least a segment, where I'll talk about the papers to give you some general feedback on top of the feedback I'll be giving you in the papers now.
Also, next unit is the last unit, correct?
The next unit, I think it'll be for you guys, Unit 6. That is the last unit. That'll be on therapy, and then Appendix B, I believe, work psychology. I'll probably throw a few more things in there as well, but that's the last unit, correct?
All right.
Okay.
Thank you.
No problem. So if there's nothing else, if you did join us a little bit late, be sure to send me a present to make sure that I have you listed here so I can give you the credit points once I start doing that. If not, you guys are free to get out of here. I'll talk to you later. Have a great weekend. Stay safe. Bye.
Bye. Have a great weekend.
Bye. Thank you.
Uh-huh.
Bye. Thank you. Have a great weekend.
You too.